future dogs, imagine this. A kid walks in with golden honey crusted sores, impetigo alert, or a diabetic with a leg that's hot, red, and spreading like wildfire, cellulitis or worse. Today on Harrison Learns, we are diving deep into infections of the skin, muscle, and soft tissue straight from Harrison's principle. Let's dive in. Starting with the bubbly ones, infections associated with the vesicles. Vesicles are those tiny fluid filled blisters from viral proliferation within epidermis. First, varicella, nothing but chickenpox. They have classic dewdrop on rose petal look, like clear vesicles on red base. Super contagious. It occurs in kids more. Next is herb zoster, nothing but shingles. They occur due to reactivation of varicella zoster virus in single dermatome. Basically, they are unilateral, follows a nerve path like thoracic or trigeminal, more common. Painful as well, especially in the elderly or immunocompromised. For these two, you can do diagnosis Zank smear. Treatment start early with acyclovir. Next up, bigger blisters. Bully. Infections associated with bully. First one is staphylococcal scalded skin syndrome. They are more common in neonates. These are caused by exfoliative toxins which are released from group 2 Staphylococcus aureus. They are basically drug induced and diagnosis is punch biopsy with frozen section. Next one is toxin epidermal necrolysis. They are full thickness necrosis. They have 30% mortality. Remember, this staphylococcal scalded skin syndrome spares mucosa, but TEN doesn't. And for TEN, the treatment is gamma globulin. Now the sticky stuff. Crusted lesions from dried out vesicles, super common in pediatrics. First one is Impetigo contagiosa. Basically, they are caused by Streptococcus pyogenes. They are more common in children in between 2 to 5 years and more common in face or extremities. Starts vesicular but then appear as honey crusted golden brown. Basically, they are honey crusted lesion. This is very important. Remember this. Okay. Next one is bullous impetigo. This occurs due to Staphylococcus aureus toxin. Basically, they are bigger bullae. Then same crusty fate. Treatment, you can give topical mupirocin for local and cephalexin if widespread. Next, into the follicles. Folliculitis, angry hair roots. Most common cause is Staphylococcus aureus. There will be sebaceous glands are blocked and it gives rise to sebaceous cyst. And diffuse folliculitis is divided into two types. One is hot tub folliculitis. These are most commonly caused by Pseudomonas aeruginosa. Basically, they are diffuse, itchy post-soak. And next one is swimmer itch. They occur when water is infested with schistosomes. They occur as papules. Treatment, you can give benzoyl peroxide topically, cephalexin if bad. Next one is Erysipelas. They occur due to Streptococcus pyogenes. Basically, they are fiery red swelling of face or extremities. The distinctive features are they have well defined indurated margins, and this is very important. They occur particularly along nasolabial fold and they have rapid progression and intense pain. Treatment is IV penicillin G. How do you differentiate it from cellulitis? Basically, cellulitis have sharper edges and they are more lymphatic. Next is cellulitis. They extends deeper than erysipelas and involves subcutaneous tissue. They are characterized by local pain, erythema, swelling and heat. They are caused by flora colonizing skin and appendages. Okay, if Staphylococcus aureus spreads from a central localized infection such as abscess folliculitis. In contrast, Streptococcus pyogenes cause more rapidly spreading cellulitis with lymphangitis and fever. Risk factors are trauma, obesity, venous insufficiency, diabetes, lymphedema. And methicillin resistant Staphylococcus aureus is rising nowadays. Diagnosis is gram stain and culture. Treatment I am going to discuss at the end of the video. Next is necrotizing fasciitis, flesh-eating frenzy. They are associated with group A streptococcus or mixed aerobic anaerobic bacteria or may occur as gas gangrene caused by Clostridium perfringens. The cutaneous features are basically divided into three stages. In stage 1, you can see them as erythema, tenderness, beyond the erythema, swelling and odd skin and rapidly becomes discolored. In stage 2, you can see blisters, bully formation, serous fluid, induration and skin fluctuation. These are basically late features. In stage 3, you can see hemorrhagic bully crepitus. Remember this, it's very important. Crepitus. And you can see skin necrosis as you can see in this image, and gangrene and numbness. Okay, if the leakage is into perineal area, there results in Fournier's gangrene. That is nothing but there will be massive swelling of scrotum and penis with extension into perineum or abdominal wall and legs. Diagnosis, you have to do surgical explore and then gram staining and culture. Treatment, you can do debridement and then you can give broad antibiotics which I will discuss later. Next is myositis and myonecrosis. Muscle involvement occurs with viral infection or parasitic invasion. First one is Pyomyositis. They occur due to Staphylococcus aureus. They occur at trauma site basically. They occur at trauma site. Myonecrosis, they are caused by Streptococcus pyogenes. They occur with necrotizing fasciitis in 50% of cases. The next is gas gangrene. They follow severe penetrating injuries that result in interruption of blood supply. Traumatic gangrene, they are caused by Clostridium species. Non-traumatic gangrene, they occur among patients with neutropenia, GI malignancy, diverticulosis and recent radiation therapy. And in non-traumatic gangrene, Clostridium specticum is most common organism. And for diagnosis, you can check creatinine kinase levels. They are always elevated, and imaging for abscess and tissue culture, and viral or parasitic for plain myositis. Treatment. If the diagnosis is animal bite, for prophylaxis or early infection, the first line will be amoxicillin plus clavulanate. Alternative treatment is doxycycline. For animal bite, if there is established infection, first line is ampicillin or plus sublactam. Alternative is clindamycin plus ciprofloxacin. Diagnosis is bacillary angiomatosis. First line is erythromycin and alternative is doxycycline. If diagnosis is herb simplex primary genital or herb zoster, then the first line will be acyclovir and alternate will be famiciclovir. If diagnosis is cellulitis, whether if it is staphylococcal or streptococcal, the first line will be nafcillin or oxacillin. The alternate will be cefazolin or ampicillin or sublactam or erythromycin or clindamycin. If diagnosis is methicillin resistant staphylococcus aureus skin infection, the first line will be vancomycin and alternate will be linezolid. If the diagnosis is necrotizing fasciitis group A streptococcal, then the first line will be clindamycin plus penicillin G and alternate will be clindamycin plus a cephalosporin. If the diagnosis is necrotizing fasciitis mixed aerobes and anaerobes, the first line will be ampicillin plus clindamycin plus ciprofloxacin. Alternate will be vancomycin plus metronidazole plus ciprofloxacin. If the diagnosis is gas gangrene, then the treatment will be clindamycin plus penicillin G. Alternate will be clindamycin plus cefoxitin. From vesicles to vicious gangrene. That covers this chapter in a nutshell. If this save your study session, subscribe for Harrison Learns and hit the bell icon. See you in the next one. Stay sharp, docs.